In critical care, there's one skill that can truly mean the difference between a planned, controlled intervention and a full-blown emergency, and that's spotting the subtle signs that a patient is getting worse. So in this explainer, we're going to break down the kind of bedside thinking that helps you act early and, honestly, save lives. And look, this isn't just textbook stuff. This is about becoming a truly proactive clinician.
And this right here, this quote gets to the very heart of it. What it means is, by the time a monitor starts flashing a scary alarm, like a big drop in blood pressure, the patient's body has probably been sending out these quiet distress signals for a while. Our goal is to learn how to read what the patient is telling us long before the numbers go critical. It's a simple mantra, right? Recognize early, think early, and act early.
Okay, so here's our game plan. First, we'll get on the same page about what it even means for a patient to deteriorate. Then, we'll talk about why your own eyes are your single most important tool. After that, we'll dive into the real nitty-gritty, the what, the specific warning signs to look for. And we'll wrap it all up with the how, a clear action plan and a mental framework you can take with you to the bedside every single day.
So first up, let's talk about what we're actually trying to spot. What does it really mean when we say a patient is deteriorating?
And here's the absolute key thing to get. Deterioration isn't like flipping a switch. It's more like a slow slide down a slope. It's the body going from a state of compensating and, just about coping to a state where it's actually failing. Our entire job is to catch that patient somewhere on that downward slope, giving us that crucial window to step in before they fall off the cliff.
And this slide just lays it all out, doesn't it? It shows you exactly why this matters so much. When you recognize it late, you're dealing with chaos, an emergency intubation, a crashing patient that is infinitely harder to manage. But when you catch it early, well, you can start treatment sooner, you can plan your next moves, and you can fundamentally change that patient's outcome for the better.
All right, let's move on to our second big idea, because this is the foundational skill for everything else. It all starts not with the beeps and alarms and numbers, but with your own two eyes.
It's such a classic trap to fall into, getting fixated on a single number. A patient can have a totally normal blood pressure but be in horrible respiratory distress, or they can have a normal oxygen saturation while their breathing muscles are about to give out. You have to see the whole patient, and even more importantly, you have to see the direction things are heading. The trend is everything.
And what I love about this list is that these are all things you can spot literally from the doorway. A patient's appearance reflects their physiology. Someone who's struggling to breathe or is becoming septic, they show it on their face and in their body language long before those big, bold numbers on the monitor finally crash.
Okay, now we're getting into the real nuts and bolts. We know we need to look, but what exactly are we looking for? Let's break down these warning signs in a systematic way, just like you would during a real bedside assessment.
We always start with the ABCs, right? So A for airway. What are those telltale signs that a patient's airway might be getting into trouble? The first thing you do? You listen. That wet, gurgling sound is a major red flag. Then you look. Can they handle their own secretions? Is their cough getting weaker? And a huge one, are they becoming less conscious? Is their GCS score starting to slide? The key here is that a patient who's losing their ability to protect their own airway is an emergency waiting to happen. You have to act before it becomes a complete obstruction.
All right, on to B for breathing. And listen, if you only remember one thing from this entire explainer, let it be this. An increasing respiratory rate, what we call tachypnea, is so often the earliest and most sensitive sign that something bad is brewing. It is so easy to overlook, but it's a massive clue.
So you're on the lookout for that climbing respiratory rate. You're watching for them using those extra muscles in their neck and chest to breathe. You're noticing if they suddenly can't lie flat anymore. And here's a critical point. A patient breathing fast is working really hard to compensate. So if they were breathing at 30 and now they're down to 12 and looking drowsy, that's not them getting better. No way. That is pure exhaustion, and it means respiratory failure is right around the corner.
Next up, C for circulation. And this is another one of those core truths in critical care. The human body is brilliant at keeping that blood pressure up until it just can't anymore. Think of it this way. If you're waiting for the BP to drop to call it shock, you've already missed the opening act. So instead, what do we look for? We hunt for the early signs of bad perfusion. You got to actually feel the patient's skin. Is it getting cool, clammy? Check their capillary refill time. Is it getting slower? Look at the heart rate on the monitor. Is it steadily creeping up? These are the clues that tell you the body is slipping into shock, long before that blood pressure number finally gives up the ghost. All right, let's talk about the brain. D for disability or neurology. Your brain is incredibly sensitive to any lack of oxygen, blood flow, or big metabolic shifts. So how does it tell you that the body's under serious stress?
Any brand new change in a patient's mental status is a gigantic red flag. Pay really close attention to new confusion and especially agitation. And I gotta tell you, it is so easy to see a restless patient and just write it off as, oh, they're just anxious. But that restlessness could be their brain screaming that it's not getting enough oxygen. It could be the very first sign of hypoxia, or shock, or sepsis. Always dig deeper.
And finally, let's talk about a silent but super powerful warning sign. It gives us a direct window into how well the body's organs are being perfused. And that silent alarm comes from the kidneys.
So when you see that urine output start to drop, that's a massive signal. And you have to remember, this isn't just a kidney problem. 9 times out of 10, it's a circulation problem. It's telling you point blank that the body isn't getting enough blood flow to its vital organs. It's a direct, measurable sign of failing perfusion.
Okay, so you've seen the pattern, you've spotted the signs, now what? What do you do? Because let's be honest, recognition without action is pretty useless. This is your immediate response plan.
The second you even suspect a patient is going downhill, you gotta act. You immediately start over and systematically reassess their ABCDEs. You call for senior help early. Don't wait and see, because that can turn into watch and code real fast. You start basic supportive measures, think through what reversible causes might be happening, and then you just keep reassessing over and over again.
All right, to bring this all home, let's build a simple mental framework, a checklist that you can run through in your head every single time you walk up to a patient's bedside.
This is it. Just 6 simple questions. Is the patient protecting their airway? Is their breathing adequate? Is their perfusion starting to fail? Is their brain function changing? Is their urine output falling? And the big one, is this trend getting worse? If the answer to any of these is yes, or even just, I'm not sure, that is your signal. That is your cue to act.
And in the end, that's really what this is all about. Most patients don't just suddenly collapse out of the blue. There are warning signs. There's a pattern. Your job, our job, is to train our eyes to see that pattern, train our minds to connect those dots, and train ourselves to act early and decisively. That is how you make a real, life-saving difference at the bedside.